Thank you for joining us for today's webinar. We're going to give folks a few minutes to continue to join the webinar, and then we will be getting started shortly. So sit tight and we will get started shortly. Hello, I'd like to welcome everyone to today's webinar, 2 Decades of Telehealth at Cherokee Health Systems. My name is Samantha Holvey, and I'm the Director of Community and Education here at WEDI. Thank you for joining us for today's webinar. Before we get started, I want to take a moment to go over just a few administrative details. As you have noticed upon joining the webinar, everyone has been placed on mute for the presentation. At the end of the presentation, there will be a Q&A session. So in your GoToMeeting control panel, you will see a questions box. Please type your questions or comments into the field and hit enter. Please note that the recording of this webinar, along with the slide deck, will be posted to the WEDI website, and downloading instructions will be emailed to all registrants. If you want to go ahead and download the PDF version of the PowerPoint presentation, it's located in the Handout tab of your GoToMeeting control panel. Today's webinar was arranged by the WEDI Innovative Encounters Work Group. This work group explores the various business aspects related to the delivery of healthcare services using innovative technologies, mainly telehealth, and the exchange of data to support the encounters. This work group meets monthly on the 3rd Wednesday of the month at 4 p.m. Eastern Time, and all WEDI members are welcome to join the calls. If you have any questions about this work group or any other WEDI work group or sub-work group, please feel free to email me, sholvey@wedi.org. The panelists for today's webinar include Greg Perry, Director of Psychiatric Services, Andy Ray, Chief Information Officer, and Jeff Howard, Chief Financial Officer. Without any further ado, I'd like to go ahead and hand it over to Jeff.
Thank you. My name is Jeff Howard. I am the Chief Financial Officer here at Cherokee Health Systems. I've actually been in this role for 20 plus years. I've come and gone a couple of times, but basically been with Cherokee for a long time. And so we get to share a little bit today about our experiences with telehealth. This has been an exciting area for us as we've primarily started this type of service for access for our patients. To share a little bit about Cherokee, we are a nonprofit organization. We started as a community mental health center back in 1960, and then we got involved in primary care in the mid-'80s. And so since that time, we've just combined the two. We're very much a mission-minded organization. Our mission statement is on the screen. It's to improve the quality of life for our patients through the blending of primary care and behavioral health. Together Enhancing Life is just a marketing tagline that a marketing company came up with a long time ago, but it really fits our mission well. Together for the integration, and we're here for improving the quality of life, for enhancing life. Our primary service area is East Tennessee. We started, like I said, in Morristown, Tennessee, Hamilton County, but since that time we've expanded. We continue to grow in rural areas, but it's really only been the last decade that we've gotten involved in some of the more urban areas. You see that Shelby County, way out there to the west, it just kind of stands by itself. That's a relatively recent expansion. We operate 3 clinics now in Shelby County. We've been there for about a year and a half. If you look at the volume, we see about 76,000 patients per year. And this is all based on our most recent fiscal year, which is a June 30 fiscal year. During that time, we had about 400,000 services, 28,000, a little over 28,000 new patients entered our system. The way we count those new patients, it is true new people accessing our services. We frequently have people switching between primary care, behavioral health, but they're really only new when it's their first time through the door. And so of those 76,000, about a little over 28,000 were brand new to the system. We've got 755 employees spread across Tennessee. Some of those employees are in other states. We have one employee in Kentucky. We have another that lives in Georgia. We frequently have people that come across the border. Since we are touching several state borders, we frequently have people that live in one and work in the other. If you look at our provider staff, psychologists, we have 47, primary care physicians, 41, and the nurse practitioners, 51. Psychiatrists and nurse practitioner psychiatry, there's 18 total psychiatric resources. We've got a lot of LCSWs, a lot of community workers. One of the other more recent additions to our staff is a cardiologist and a nephrologist. We have a difficult time finding specialists for our primary care patients, so we found it helpful just to bring some in-house. They do see our patients, but they also consult with our primary care providers to help them handle certain situations. In support of our mission, we have certain strategic emphases. The first and foremost is the blending of behavioral health and primary care. We've become a little bit well known in that area. We do consulting with a variety of organizations related to integrating behavioral health and primary care. But that is first and foremost our strategy and our clinical model. Go where the grass is browner or brownest. We have expanded quite a bit, and that's mostly been through moving into areas that have need. And so we just have a saying that we go where the grass is browner, because we do look for the areas of need. Outreach and care coordination, we think that's valuable to care. We're here to serve our population, not just the people that come to our clinic. So we need to reach out to those people that are around us. Telehealth has been part of our service mix for a long time, so that's certainly an emphasis of ours. We think it's important to train healthcare providers. We have a lot of different training programs. We're involved in a residency program for primary care. We also have an internship program for American Psychological Association. We do a lot of training with nurse practitioners, with nurses, with just a variety of different types of positions. We think value-based contracting is important. We don't like fee-for-service. We'd prefer some type of arrangement where we get paid for results. And also healthcare analytics is an important part of what we do. But we're here to talk about the telehealth, and I'll let Dr. Perry pick up from here.
Good afternoon. I have also been with Cherokee quite some time. I've been Director of Psychiatric Services for nearly 20 years. And in the mid to later 90s, we were having a real struggle trying to get especially psychiatric services to our rural areas. It was very hard to recruit providers. And so we began doing some research and looking into the idea of telemedicine. In doing some research, I learned that the first published reference that I could find to telemedicine services occurred actually in 1924, which was well before the use of TV. But it was the cover of Radio News. And for those of you who see it on the screen, you can see a huge boxy machine that appears to be in a patient's home. And on a screen on the machine, there is a physician who is looking at the patient and obviously getting some kind of parameters. This was really quite a bit of foresight that went into this. It was at least another 20 years before there was a real demonstration of telemedicine at the World's Fair, although it really only occurred between two rooms, but it gave a glimpse of what could occur in the future. Moving forward to 1955 or so, the first true telemedicine service was established at the University of Nebraska, and it offered psychiatric care to some remote sites. Following this, there was a number of programs that popped up with grant support, but the technology was enormously expensive. And so once the grants ran out, all the programs pretty much were forced to close. We moved forward to the mid-90s when, with the advent of the internet and teleconferencing equipment, it became possible to actually fund something like this without grant support. So back in the mid and later 90s, as all of the things on the screen were going on, we began our first telemedicine service to one of our very remote clinics up on the Kentucky border. We did it using teleconferencing equipment over regular telephone lines. And if you notice the character in the bottom left of the screen, our good friend Max Headroom, I'm afraid that's what I looked like at times. The picture was very jerky. It was not consistent. It did not do a whole lot for patient confidence in the system. So we switched to ISDN lines and then very quickly learned that T1 lines were really the way to go that would make this service work. And we have continued to use a combination of T1 lines and now fiber optic cables that connect all of our clinics. Today, we use telemedicine for primary care services, for a number of mental health services, both therapy and psychiatric care and crisis services. We do behavioral health consultant consultation. We also do telepharmacy. We have a main pharmacy with several satellites, and the pharmacist at our main site can provide counseling to patients at any of these satellite locations. We can interface with local hospitals for discharge and aftercare planning. Our mobile crisis workers can use our telemedicine services when they're out in the field. We can work with the mental health hospitalizations for second certification for commitment. We can use interpretation services. We can use it for treatment teams, so we can have some members who are not in a clinic full-time still beam in and join the treatment team at that location. We do quite a bit of clinical supervision through it. We offer often some groups, such as the hypertension group and the nutritional group. Our community health coordinators can use it, patient-child interactive therapy, and online care of a primary care and behavioral services is something that we're looking into now so that in acute situations, we can reach out to the patient where they're located rather than essentially forcing them to come into a building or a clinic of some sort. They often say that a picture is worth 1,000 words, and so let us show you some pictures of what we do. This is our basic setup for psychiatric services. We use special lighting, which is not fancy. In fact, if you look carefully, you can see that's just PVC pipe, some ceiling tiles and work lights that I found in the bargain bin at Lowe's and put together. We have screens, computer screens in front of the clinician that do not show on camera, but they contain all of our electronic records. We use a person at the remote end who is the person you're seeing on the screen. That is one of our telemedicine nurses. They are responsible for bringing the patient in, explaining the service to the patient, staying in the room to handle any sort of chores like getting sample medication or scheduling further appointments. This is typically how our psychiatric services run. This is another office where we have a psychiatric nurse provider, and you can see that is what she looks like on her end. You can see in the office where we have a simulated patient sitting in front of the camera along with the psychiatric nurse who stays in the room, and seeing the provider, nice and lifelike size. You notice that the wall behind the provider is painted a specific color, as is the wall behind the patient, in order to provide the best visual image to both the patient and the clinician. This setup is a pediatric nurse practitioner who can send herself to any one of 25 different schools in Sevier County and offer acute care for staff and students. At the remote end, the school nurse has access to specialized instruments that transmit cardiac sounds or can transmit video pictures of throat, ear, skin, things like that. This is one of our newer setups, and this shows one of the newer video cams that can attach to the system, and you can see the really high quality resolution that you can see for if you're looking at skin lesions. So the patient can also see what's going on, what the clinician is looking at, what they're concerned about. This is another view of the same kind of equipment, this time looking in an ear and looking in a throat. The clinician also has the capability of doing a freeze frame. And so if you can get a good picture of the throat, they can freeze frame that to examine it carefully without the tongue wiggling all over, which we'd actually find if you were doing it live in person. This is our telepharmacy setup. And on the top left, you can see one of our pharmacists at our main clinic, and she is holding something she needs to explain to the patient. You can see both the pharm tech and the patient on her screen. On the second screen is all the medical records and the pharmacy records that the pharmacist has access to. On the bottom right, this is what the patient would see. They can ask questions, they can be instructed in how to use the testing material, and we actually do this quite a bit. This took a concerted effort to get permission to do this from the Tennessee Board of Pharmacy. They were initially very against this, and we lobbied long and hard enough to get them to allow us to at least do a one-year pilot program, which was so successful that we are now able to do it full-time to our satellite clinics. Mobile crisis workers spend a lot of time on the road, traveling between emergency rooms or clinics, And so they now have the capability of logging on when they're in their car or when they're in an office to interact with clinicians, with patients, with emergency room staff. So this has been very helpful and saves at times actually quite a bit of time and driving. Here's a number of our setups that are currently in use. All of our screens at this point are high def. Generally, the cameras are on top. On the upper left, that is one of our tech staff setting up a psychiatric office. In the middle is one of our primary care setups that includes the specialized instruments that are connected. On the top right is a psychiatric nurse practitioner who sees patients in one of our inpatient units and in 2 different remote clinics. That's essentially the same setup on the bottom. In the middle and the bottom is an iPad that we can use in certain situations to set up to speak to the patient. And in the bottom right, many of our laptops now have cameras built in, and we can see the smiling face of one of our super IT techs checking it out. But we can do that from any number of our laptops at this point. So far in 2017, you can see the number of visits that we have had for therapy or behavioral health consultant work, for psychiatry, for primary care. This is only part of the total. These would be considered the clinical visits. They do not include all of the supervision that we do, the pharmacy, and a number of other things that fit into the non-clinical category. So you can probably tell from the numbers at this point, we are highly invested in telemedicine, and in fact would have a difficult time if we did not have this technology available.
So you see, technology is one component, and we seem to have that all figured out. It's working well, has been working well for a while. I guess the little more difficult piece from my perspective is, how do you get paid for this? And so let's look at some of the issues here. First, it is extremely convenient for patients and for providers to have care in this manner. You see, in both cases, the individual is sitting at home. We do have several situations where we have providers seeing patients from their homes. Our director of primary care lives in Lexington, Kentucky, and when she sees patients, she's seeing them at pretty much any East Tennessee location, but primarily in Morristown, Tennessee. And so she can beam into any office, and she does do it from an office within her home. We've got another provider, a psychiatrist, who sees kids in East Tennessee, but he lives in Georgia. So we have made use of the technology to allow providers to stay with us even when they've moved. And so it's convenient. From the billing standpoint, Medicare does reimburse for the patient's location if it's in a valid location. And that Q3014 code is what's used. It's not a large reimbursement. I think it's in the $20, $25 range, but that is for the patient's location, the originating site. The distance site is the professional service, and that's billed with a GT modifier called the distance site or the remote site, and that's the provider's location. Now, different states have different rules associated with telehealth. You see the very first box there, the definition. 48 states and the District of Columbia have a definition for telehealth. I thought that was interesting that there are 2 states that have not yet defined it. And those two states are Alabama and New Jersey. And so it's interesting also that New Jersey does reimburse for telehealth, even though they don't have a formal definition for it. So Medicaid reimbursement is the next box there. 48 states reimburse for live video. And so with that, Massachusetts and Rhode Island are the only ones that are not currently. And this was as of April of 2017 when I last looked at that number. 19 states will reimburse for remote patient monitoring. Unfortunately, Tennessee is not one of those yet, but being able to monitor a patient at home rather than them coming in and reporting certain data, it's extremely useful with this kind of technology. There's so many different types of devices that could be used to remotely monitor patients. So fortunately, more and more are allowing that. So you can see different states have the different rules. The other one that I thought was interesting was the consent. 29 states recommend or say that there has to be some sort of informed consent that you're seeing the patient in this way and that they're agreeing to this type of service. Licensure can be different in the states. Some states have a specific telehealth license, others do not. Tennessee, I found out that Tennessee no longer has that for MDs, but for DOs, they do still have a specific telehealth license. Parity laws have been real helpful for us. With the parity law, it basically says that private insurance companies have to treat telehealth services as they would a face-to-face service. And so most states do have some type of parity law. Alaska has partial, but the other light orange states would have a proposed law. But the dark colored states have no parity legislation active. Hopefully that will change because that does help with reimbursement by the states requiring that they pay for it. If they participate in a state-funded program, then they would have to cover it as if it were face-to-face. Now, there's some good resources. This is American Telemedicine Association. Good resources for seeing what applies in your state. And so for this chart, 2017, Tennessee did have the parity coverage. They did have legislation for Medicaid to cover the services. And then there's other things going on. The most recent was that Tennessee now recognizes schools as a legitimate patient setting in the parity law. Some of the issues that we've had to address over the years is Medicare, and then there's state-by-state policies that creates inconsistency with how it's billed. So Medicare may have one rule, whereas the state Medicaid plan might have another rule. And also, if you serve patients in multiple states, that creates inconsistencies. One of the other areas we've had to address is if the provider is located in one state, seeing patients in another state. So there are some inconsistencies. Early on, there was some talk about requiring that there be a hands-on initial visit for any patients to be seen in this way, and then periodic hands-on visits in order to keep that patient active. Fortunately, that did not pass. So at this time, at least in Tennessee, we do not have any requirements that say we have to see them in a hands-on visit to initiate care. Controlled substances restrictions. There was also talk of restricting the types of medicines that could be prescribed. We also find that states look at ways to balance access and restrictions. Access is the primary goal for this type of care, but then you also need some type of restrictions so that it's not overused or used in place of a primary care relationship. I know there's organizations now that will see patients for quick types of care. We actually use one in our employee health plan. That is not a primary care provider relationship. It's just a quick service to prevent somebody from having to go to the ER, basically. But that does somewhat interfere with the PCP relationship. So it is a balance, and we need to make sure we look at it in that way. We want primary care to still be, we stress the importance of primary care. We don't want to take anything away from that. A Medicare definition of originating sites does not include the home or community or other similar sites. That makes it difficult if you want to provide care to a patient that is at home. There are home services that could be billed if it's legitimate home care. But if you're, one of the ways we use it is if our community health coordinator were to go visit in a home and the patient needs to see their PCP for something, we have the technological capability of connecting the two. But in that situation, we don't have any way of billing for that. And then there's confusion over whether or not providers at FQHCs are eligible. There was some clarification that came out a couple of years ago, and it basically said that RHCs and FQHCs, or rural health clinics and federally qualified health centers, are not authorized to serve as a distant site for telehealth consultations. So in our scenario, we have locations that are federally qualified health centers. We have providers at those locations that see patients at other locations of ours that are also FQHCs. So based on this guidance, we could not bill a professional FQHC service being provided to a patient in that way. But then the clarification also says that nurse practitioners and physicians and LCSWs, PhDs, they're all allowed providers, so they can see patients, but billing it as an FQHC is not an allowed service. So there is confusion over the billing from that standpoint. Another thing we run into as a federally qualified health center is that the UDS, the Uniform Data Set, which is the data that all FQHCs file with the government, the UDS does not recognize telemedicine services. It's considered an exception. So these patients and these persons do not count as a visit for UDS reporting. So even though we're providing the care, we're seeing the patients, those do not count for primary care. However, they do for psychiatry. So there is still confusion.
Next, we're going to talk a little bit about the initial challenges we have with telemedicine. And I'm Andy Ray. I'm the Chief Information Officer with Cherokee. I've been here for 18 years, right at about the same timeline that we've been doing telemedicine. So I can remember kind of one of my first projects starting off here was looking into telemedicine technology and trying to get it up and running. So, back in those days, if we have any true appreciation, any IT folks on the line, we were trying to connect up, in the beginning with 56K dial-up lines, and then we got really super high-tech and really geeky trying to bond two of those connections together and trying to get 128K out of two phone lines. But back in those days, it was complicated. It was hard to get a consistent connection back to the distant site. And so we started off with really expensive video equipment, and we started off with Polycom. And it wasn't unheard of to spend $8,000 or $12,000 on just one video unit. And of course, you have to times that times two, because you need one on the provider side and one on the patient side. Then we had this really complicated network infrastructure setup, which required, special routers and special switches special video infrastructure back in the data center to make all of this work. And then we faced really expensive and inadequate internet bandwidth, where we had to pay, have to go to AT&T, which was about the only carrier that we could get service from back in the late 90s and early 2000s in our area, to be able to provide us the adequate amount of bandwidth to provide the service. And we actually had to pay more for specialized service to be able to carry video over those connections. And then we had to, we struggled with finding dedicated office space. Just like Dr. Perry mentioned, you've seen in those pictures, some of the equipment can get quite large. We had special lighting, special wall colors to be able to make this setup work. And then provider buy-in. A lot of times providers just didn't believe in the technology, that they were able to see patients over the TV, over video, and be able to diagnose a patient like they could in person. And, also training providers and nurses on workflow, a little bit different. Providers or nurses are used to being together. They're used to being together in the same room, in the same building, and now they're in two separate locations. So now things are much easier. From a camera standpoint, now you can just boot up a laptop and connect with your webcam. It's inexpensive plug and play video equipment. You can do this with iPads, iPhones, webcams. Just about anything out there has a video camera on it. You can make telemedicine work. And because we can make that work, it's because we have easy to use, and some of these services are free, cloud-based video services. So we no longer have to depend on expensive video infrastructure sitting in the data center, taking up valuable space. Now we can use cloud-based video services from Zoom and BlueJean and Spark and Polycom and some of those cloud-based video services where IT staff, they don't have to be as involved as we used to be. Now broadband's pretty much everywhere. In our area in East Tennessee, we're very fortunate to have broadband widely available, and now we can get Comcast Charter, Time Warner, Level 3. All of those are available to us at a very competitive rates in most all of our offices. Dedicated office space no longer required, just like you got to see in the picture that Dr. Perry talked about. You had mobile crisis sitting in a car. They could be in a Walmart parking lot, be able to evaluate someone sitting in a local ER. So that office space is no longer required. It's preferred, but no longer required. And providers, they've read about it now. They've seen it in action. They believe in it. And providers rarely fear the use of telemedicine technology. And here at Cherokee, we just think of telemedicine being part of our everyday workflow. It's not something that we think of as a separate service. It's just part of what we do.
And one of the things I thought of as Andy was talking about the current environment, Dr. Perry used to talk about the setting needing to look like 6 o'clock news. And so the lighting was extremely important. People were used to seeing screens of that quality. And now with the proliferation of iPhones and iPads, there's really no restrictions on the quality of the video because people are used to small screens. They're used to the automatic lighting controls. So they don't get so hung up on having to see that perfect picture. But we still do try to emphasize the quality of the picture, because the quality of the picture really is reflective of the quality of the service in the patient's mind. And so we need to be a few notches above what people are used to.
After having done this for nearly 20 years, we have learned some important lessons that we can pass along. Number one, patients always point the way. If you are thinking about a telemedicine service, you need to identify what the needs are, but also what are the patients willing to do? How far are they willing to travel? what can you do to make them comfortable in the setting? Number two, good technology is essential. As Jeff was saying, even though people are very used to little tiny screens on their phones or tablets, still put up a good picture. The more professional it looks, the more it will be taken that way by the patients. Number three is one that I think is often overlooked, but you have to have management support to begin a service like this. There are initial costs, there are billing issues, there are other considerations that have to go into this time-wise, and without management support, it is very difficult to make this service work. Number four, billing can be difficult. That really ties into number five. We do a lot of advocating for policy change so that we can make the billing work. The last one is keep it as simple as possible. It is not that hard nowadays with the technology that's out there to provide a professional looking service for a far lower cost than when we started 20 years ago.
You know, one other point that we didn't really highlight is what happens when the technology doesn't work. You know, over these years, we have had situations where the lines have gone down. We've had situations where equipment stopped working. And so you really have to have some type of backup protocol in place if you're going to do this type of service. And that could be from having somebody fill in or having a backup phone line.
In our initial protocols, we insisted that there had to be a working telephone in every office where the clinician and the patient were located. And we had a routine that we went through on the rare occasions when the video went down, that calls had to be made to the nurse at the patient end and certain procedures were followed. Nowadays, of course, everyone seems to have a cell phone and we no longer require separate telephones in the room. We still have a procedure that we follow if the video goes down and how the nurse and the provider will contact each other and how to proceed from that point so we don't make the patient uncomfortable.
And I'll add to that, you know, back like Dr. Perry and Jeff were talking about, we had that backup telephone line, but now all of our CHCs and which is our community workers, they're outfitted with iPads that are 4G, connected with 4G to our Verizon network in East Tennessee. And so now when we have an outage, we try to utilize those CHCs and we try to bring those CHCs back into the office immediately with their device where we can continue telemedicine services. The only that would not work for would be for primary care, but it would work for all the rest of the services.
And like I said earlier, there are lots of resources out there that can assist an organization in this area. There's the American Telemedicine Association. So like I showed you some of the charts from the states, the Telehealth Resource Centers, Center for Connected Health Policy. These are just three of the organizations that we've leaned on to find good information. So that pretty much wraps up our history in just a few minutes. We have learned a lot of lessons, but at this point, if you have any questions for us, we are here to answer.
Hi, this is Nancy Spector. I'm one of the co-chairs of the WEDI Innovative Encounter Work Group, and I'll be facilitating questions for our presenters. And if you'd like to ask a question, you can type it into the question box in the panel. That is with the webinar, the panel there. So you can go ahead and type questions in. I actually had a couple questions that I thought of as you were presenting. So I'll start out and then I'll give people a chance to type. So one of the things, I mean, you talked a lot about, you know, the patient and what they do. I was interested, I'm sure you do overall patient satisfaction, and I was wondering if you've done anything to compare satisfaction rates with the telehealth services compared to what would be your traditional office services.
Over the years, we have done informal studies on this exact question because it's an issue we have always worried about since we started. What we have found is that the satisfaction appears to be identical between face-to-face visits and between the telemedicine visits. And I think that a lot of that has to do with the fact that we just don't put a patient in an empty room by themselves with a TV screen. We always have that human contact present.
I enjoy hearing the stories about the patient's reactions when they actually see their provider on TV. And I believe there was one story where the patient said, "See, my TV does talk to me."
That actually did happen with one of our schizophrenics. In the very early days, we were concerned about people with psychotic disorders, whether if they could tolerate talking to a television and having someone on television talk back to them. What we learned is that even patients who experience hallucinations that the TV is referring to them, it does not happen with all TVs. It does not happen in all circumstances. And really, we have never had a problem with that. The patients have always been to differentiate between the fact that this is a clinician speaking to me. I think our worst case scenarios have been with some of the psychotic disorders that become essentially catatonic, and they have a poor time responding to a television set. And in that case, the psych nurses at the patient end are trained what questions to ask, what we need to know, how to get the family involved for history if we need it. So we have a whole routine. That doesn't come up very often, but we are prepared for it.
Okay. Here's one question that's come in, and I'll paraphrase a little bit. Is there a particular software platform that you use for your telehealth services? Is it something from a vendor, or is it something that you've sort of built yourself?
We didn't build it ourselves, that's for sure. We have purchased, have a large investment in Polycom video infrastructure. So all of our software is Polycom, and all of our video endpoints and hardware is Polycom as well. You know, if I had to do over again and we were starting from scratch today, would I do that? Probably not. I'd probably look at a cloud-based solution. We could still use video or Polycom video units or Tambert or Cisco video units or LifeSize or something like that. But I'm not for sure that I would get myself locked into a vendor from a software standpoint anymore.
Okay.
We are
comment on that.
So we are looking at a mobile device-based app for some video services. This will be more the online type services for our specific primary care patients, our assigned lives. We do think it's valuable to have that kind of contact, and that is something we're working with a vendor to develop, but it's not something we're doing in-house. We're just working with that web app developer.
Yeah, and that's proprietary technology on the back end for the video. One video cloud-based service that I would highly recommend if you were just now getting started would be Zoom. We do use that internally some with our mobile crisis team. It makes it really easy to communicate with the hospitals. We also use it for some consultation services as well. So Zoom would be one that I would look at.
Okay. Another question, person's asking, from the patient perspective, is this something, are the telehealth services part of, is it part of a bigger approach within a patient portal for providing the services? Or I guess
there is no, maybe we'll all three answer this, but there is no direct link to the patient portal at this time. So like Jeff said, we are developing an app that we're going to roll out, and have all of our patients will have the ability to have access to that if they have a smartphone or an iPad or an Android device, to be able to see us online. So we'll meet them wherever they want to be, whether if they're on, if they're sitting in the Walmart parking lot, or if they're at school, if they're on their lunch break. We're going to be able to see and access our patients. Hopefully, I don't know if it'll be 24/7. That would be the end goal. But I don't know if you all want to tag on that or not.
At this point, the vast majority of our clinical services occur with a patient in one of our clinics. They come to one of our clinics and are in the system there. They don't enter through an outside portal.
Okay. Another question came in. Do you recommend a consent or a waiver of some sort for seeing patients while the patient's at work? So, like if they're work, have a lunch break, and the person's saying, particularly thinking of a worst case scenario where emergency personnel need to be called, and the work site inevitably finds out that the patient was having a therapy or medication management session via telehealth while at work. So do you have any kind of special consent or waiver?
We currently don't have any kind of services like that. If our CHCs are going to see a patient, it would not be at work. So I would think that would be between them and their employer, but we would not recommend that they see us from their job while they're on the job.
Okay. Wow. Getting more questions coming in. This is good. And we're bouncing around a little bit, but the next one is asking if you have any dashboard that tracks specific clinical, financial, or operational measures related to the telehealth program.
We have a lot of dashboards that measure quality and productivity, but we do not specify telehealth in that. It's just another part of the service. So we have the same expectations out of a provider seeing patients by telehealth as we would face-to-face. So we do have lots of dashboards, but nothing that pulls out telehealth specifically.
And I'll add to that. I mean, we have looked at providers that are solely telemedicine providers when we're looking at quality metric data, and there's no difference there that I notice when we're looking at the data.
Okay. Next question is, where does the clinical staff document the visit? Is it done in a separate platform, or is it part of the institution's main EHR or paper chart, whichever you have in that location?
Yeah, everything is documented in our EHR system. So, Polycom does not have, any kind of software to be able to document that visit. So everything is documented in our next-gen EHR. Now, there's other platforms out there like AMD Telemedicine. If we use them from a primary care standpoint for our instruments, stethoscopes and ENT scopes and ophthalmoscopes and general exam cams. They do have a software package that will allow you to chart and then export that or send it to a provider or to your organization. So if you are maybe a contract provider and you're working and you need to send it to multiple EHRs, AMD Telemedicine can handle that. There's several out there that have that ability as well.
I think that's one of the issues that we found with referring patients to a specialist and seeing them via telehealth. There's no connection there with the documentation. We have the same documentation on the provider side that we have on the patient side. And so it's wherever the doc is, they can access the chart just as if they were in-house. But not being able to share that record or that data would make it difficult for the provider seeing the patient.
Okay. Another question. In terms of, you talked about you've got a long history with doing the telehealth services, and you talked a little bit about getting provider buy-in. Do you have any sort of estimate as to how long it took for providers to really assimilate doing the telehealth into their general practice workflow?
This is an interesting question. When we began almost 20 years ago, we had a little bit of a bias that older providers would probably not want to do this service, and that younger providers would be more open to it. That proved to be totally false. And many of our early adopters had a long clinical history already, but could clearly see the advantages of using the new technology. In the intervening 20 years, most of the younger providers that have come to us have come out of residency programs that use telemedicine as part of their training program. And so nowadays, it's rare to have a provider who has not had some exposure to telemedicine during their training or during their clinical experience. I find that it's very uncommon to have providers balk at doing part or all of their service through telemedicine equipment now.
Okay, interesting. Another question came in about specifically about coding. So it says the 95 modifiers used for commercial carriers and GT for the Medicare and Medicaid. Are there other insurance carriers that will not reimburse? Are there any CPT codes that are not covered for psychiatry? I'm guessing if in answering this, you're going to have to, this is your personal experience with this. Might not necessarily mean it's relevant for everybody.
Right, and it differs between the payers. At this point, we've had, I hate to say it, one of the biggest Blue Cross plan for years. They considered this experimental and would not reimburse for it, but now with the parity rules in Tennessee, we are getting reimbursement. We really haven't found any that will not reimburse for it, but we do occasionally run across services that cannot be provided in this way.
Okay. I had another question that I wanted to throw out to you guys. I found it very fascinating, and you mentioned this a couple times about the how you came up with the wall color that there were definitely environmental issues or environmental factors that you learned about or had to take into account in setting up the spaces for both the provider and the patient. And I was wondering, is that all information or learning that you just figured out on your own? Was there any sort of resources that you were able to tap into in terms of how to set up the areas? Because I just found that very interesting.
Well, this is Dr. Perry, and I will admit that prior to medical school, I had a long and checkered past, and I was in the entertainment business and did a number of work in TV studios and some film studios and the PBS station in Nashville. And so I had a good sense of what created a professional picture and how to work with the auto iris features of the early cameras. With a dark wall, the camera would see a dark scene and would open up the iris, which opened up the clinician and the patient's face so they were easily visible. I will take the blame for much of that.
And I'll also add to that, Dr. Perry started that a long time ago, but it's kind of funny. The vendors kind of, they caught on to this, because if you go look at Polycom documentation now, they will recommend paint colors. There's 3 or 4 paint colors that they'll recommend to paint the walls in the rooms that you're providing video conferencing equipment in. But Dr. Perry pioneered that.
The Perry method. There is one last question, and maybe we can get to this quickly because we've got 1 more minute. So the last one, how does the patient register for the service if they're a new patient?
They come in just like they were coming in to see a face-to-face clinician. They come into the clinic and they check in at the front desk. The nurse will come back and get them. They'll either go to an exam room if it's face-to-face, or the nurse will explain that the provider will be on TV and how it will work. And they will still go to an office and sit down either on an exam table or in a chair, and they will interact with the provider.
Yeah, the consent's the same regardless.
And that speaks to the fact that you have a staff person there assisting with the telehealth services.
Yes, the only time we don't would be in a psychotherapy session. But even then, a staff person would bring the patient back, would make sure that they are comfortable and that the equipment is up and running, and they would immediately start interacting with the clinician, and the staff person would leave in that situation.
Okay, we're at the top of the hour. Sam, do you want to step in and do some final closing remarks?
Thanks, Nancy, and thank you very much to our fabulous panelists. It's been a very interesting webinar for sure, and I'll be following up with all of our attendees with the PowerPoint presentation. You'll get the slide deck, and you'll get a link to download the recorded webinar. Of course, no additional cost. So thank you, everyone, for participating today, and I hope you enjoy the rest of your day.
Thank you.